improve risk adjustment and quality programs. My name is Sean Forster, and I'll be your moderator for the next hour or so. Before we get to the presentation, I do have a few housekeeping items to go over with you today. During the presentation, all participants will be in a listen-only mode, so no need to put your ringer on silent. Also, today's webinar is being recorded, and it will be made available on our website in a few days' time. Although lines are muted, we do encourage you to ask questions during today's presentation. To do so, simply submit any questions using the questions window located on the right side of your screen. Type your question into the box, click send, and they'll be sent directly to a meeting organizer to queue for the Q&A session we'll host at the end of the hour. Should you encounter any technical difficulties during the webinar, please also utilize the questions window to describe your issue, and one of our support staff will follow up with you to troubleshoot. The most common issue we see is typically with the attendee audio connections. That can usually be resolved by either switching to a phone line or exiting and rejoining the webinar. With that, I invite you to sit back, relax, and enjoy today's presentation. Today we'll be hearing from two speakers. Tom Peterson brings more than 25 years of experience in healthcare. Prior to joining the CO team, Tom was the CEO and co-founder of Clear Vision Information Systems, which was acquired by CO in January of last year. In this role, he helped design software and services to optimize care and revenue for plans and providers across the country. Tom brings a unique perspective, having held positions at major health plans, including Blue Shield of California and Blue Cross of California, as well as providers such as Cedars-Sinai Medical Center. His extensive background in clinical data related to risk adjustment, system design, and analysis, provider outreach, and training collaboration led to his involvement in the Industry Collaborative Effort, or ICE. In his role at CO, Tom leads the operations in Westlake Village, California, overseeing the strategic direction and IT innovation to ensure alignment with evolving industry needs. Joining Tom, you'll also hear from Rachel Hall. Rachel is a senior business analyst with CO, and in this role, Rachel looks after all aspects of risk and quality, including HEDIS, STARS, and P4P. Rachel started with Clear Vision in 2009 and has grown within the company, learning about risk and quality from her positions in the operations and IT departments. Before joining CO Health Analytics, Rachel worked for 20 years for a diverse range of organizations, including Disney, IPI, Brown & Ferris Industries, and the City of Burbank. In these roles, Rachel was responsible for office management, accounts receivable, and accounts payable duties. When not working, Rachel likes to paint, ride her bike, and spend time with her daughter. With that, I will step aside and pass things over to our speakers. Rachel?
Good morning or good afternoon, depending on where you are in the country right now. I wanted to take a quick minute to share something about myself. This is the first webinar I've ever done, and I'm both excited and also really nervous. Like a lot of you on the line, I find that public speaking can be terrifying. And while the webinar style, and with the webinar style, it's true, I can't see you and you can't see me. That actually makes it more challenging because I don't have the ability to look out at the audience and see your faces as I'm talking and look to see if what I'm saying is making sense and getting feedback from your expressions, letting me know whether or not we're on the same page. As I was preparing for this webinar, I realized that the relationship between a provider and a health plan can be a lot like this. For example, without a good line of communication set up, a provider can be pushing data to the health plan every month and not getting feedback on whether it's received, if it's in the format the health plan is looking for, and if the health plan is in turn getting this data to CMS. Without this communication, the provider and the health plan won't know if they're on the same page or not and can end up working counterproductive to each other. It is important for the health plan and the provider to have clear and defined agreed upon goals that are achievable. Having transparency between the health plan and the provider towards these goals will make them easier to achieve. After all, we want the same thing: quality care for our members and proper reimbursement for that care. In this presentation, we've drawn the analogy to a rowing team. Unless the team is well coordinated and rowing in the same direction, they're not going to get very far. And so today, Tom and I are going to share some thoughts on how to improve payer-provider collaboration as it relates to risk adjustment and quality programs. We hope that by the end of today, you'll have some new strategies and approaches that you can implement at your organization. Here's our agenda for today. We're going to start with talking about knowing each other and having transparency on many levels between providers and the health plan. From there, we're going to talk about some strategies around building consensus and developing joint goals. Once you have that consensus and that vision for where you want to go, we're going to spend a section on some strategies on where you can work smarter. We all have enough work. We don't want to work any harder than we have to, but where we can streamline so we can achieve our goals in a way that avoids abrasion and is doing smart things at the right time. And then once you have the program up and running, we're going to share some thoughts around how you can continually fine-tune so you can continue to improve over time. For a lot of people on the call, you may be at the beginning stages, and we don't want to get you overwhelmed with kind of advanced goals that we might talk about a little bit later. But what we want to do is show how you can take some first baby steps and kind of have that snowball into where you have a really well thought out, well planned, and well executed program to meet your risk adjustment and quality goals. With any remaining time, we'll set aside for questions and answers. Starting out, you're going to want to have a good understanding of who you're working with and where they are in the spectrum of risk adjustment. There are a lot of different metrics that you can use to gauge an organization on, and here are 3 that we found to be the most important to use that we see such a wide range in. Different organizations have different ones, but these are the 3 key ones to start with. So for the risk adjustment sophistication side, on the one side you could have someone who is not doing anything at all or thinking of programs as retrospective activity, particularly on the providers. They might not understand how the documentation comes back to them and impacts what they're being paid, particularly if they're not a % of premium relationship. They're probably not going to have too much of an understanding of what the risk adjustment is, how it is impacted, how what they do is impacting the reimbursement of what the health plan gets. On the other side of the spectrum, you have a team that is going in prospectively, identifying where there's problems in the member, provider, and global issues that we'll talk about in a minute, and closing those deficiencies prospectively. That would be on the more advanced side. For the human capital side, do they have a team of coders on staff at each location, or is the same person who opens the mail the one who submits the data? We've seen it where you have organizations with a staff of 20 coders and organizations where the medical director's teenage son is helping out. So it can really swing in a wide direction on this one. And their use of technology would be, are they technologically savvy and perhaps using a risk adjustment data solution, or are they using Excel spreadsheets to track their data? Having a better understanding of these factors will help to better understand your partner. And this can go both ways as well, health plan to provider, provider to health plan. Okay, so this is a really good example of understanding how important transparency is to this particular process. What this slide depicts is we can see the members that have gaps in care. That's relatively straightforward. Looking a little harder, you can identify provider-specific concerns, such as physicians with low scores, but the true hidden issue, just like with an iceberg, is what lies beneath the surface, oftentimes unseen, and that's the global process issues. Part of that could be data flow issues, and part of the transparency process is both entities, the provider and the health plan, showing what they have and asking, is this right, or do you agree? There's really only one person that can tell you if that's correct, and that's the physician who saw the member. So transparency in this realm is paramount because the issues you may uncover won't just be relative to you as the plan, but they could be relative to every contract that you have. Nobody knows that until you actually open up the book and say, tell me, does this align with your reality, yes or no? Of course, overall, you want to avoid all of the iceberg, just because the big issues are the global process issues. Certainly address those, but don't forget about what is right in front of you as well, like the member gaps, etc. So you want to avoid the whole thing, but be aware of what the whole thing is as well. And also, depending on where you sit, whether you're on the provider group side or the health plan side, you might be seeing different parts of the iceberg. You're both looking at the members. As a provider, you aren't seeing any gaps, and the health plan might be looking at the members and seeing a ton of gaps. And that kind of shows what's underneath a bit, so your perspective might be a little different as well, but the transparency will help define the issues together. We recently did a survey in the industry to find out where Medicare Advantage organizations are in the spectrum of this new world called EDPS. And only about half said they thought they had a handle on it, and the other half ran the gamut from I think I have it to I don't have it at all. And this is a really good example of the challenge the industry has faced in aligning those two realities. So this example here depicts the discrepancies between members that have assigned HCCs with RAPS data versus that same population that have diagnosis codes that triggered HCCs in the EDPS world. Both of these approaches are after the same thing, identifying members that have chronic conditions so that health plans and providers are reimbursed properly. So in this example here, there's almost a 49% difference, and this is a global issue. So if this is a plan, you have this across your entire network. And if this is a provider group, you have this across your entire panel of physicians. And this transparency is a clear sign that there's an underlying issue, since these should be almost the same. We try to set a goal of less than 5% discrepancy. What we just talked about was an example of a global issue looking at EDPS data. A few additional red flags you can be looking for are missing reimbursement forecasts. Now this can go two ways. If you've made a forecast of what you think your numbers will be and you aren't hitting them, then there may be an issue. On the flip side, if you aren't even able to create a forecast for what your numbers should be, then that certainly shows an issue with transparency. Like the phrase goes, if you don't even know where you're trying to get to, how are you going to get there? Another red flag would be submitting your data to an EDI vendor without sufficient oversight or feedback. We recognize there's a value in using an EDI vendor, such as efficiency, and they specialize in submitting data, amongst other things. So we're not saying don't use an EDI vendor, but what we are saying is if you decide to go that route, you want to make sure you have an oversight and involvement in the process and not have a hands-off process putting all your trust in the vendor. If you aren't getting anything back from the EDI vendor letting you know what was accepted or rejected so you can work your errors and resubmit, this can lead to data issues and gaps that aren't really gaps and not being reimbursed properly. Also, things like not having an understanding of the filtering logic being used, not meeting with your payer to discuss where you are, and sharing your data to make sure you're on the same page can lead to a lack of transparency. And then working with multiple risk adjustment software solutions can lead to confusion, lack of clarity, and lack of productivity. Kind of like it would be if you had 6 different email accounts and 6 different cell phones that were linked to. It would be hard to stay on top of them and stay declarative when you have that many things to check and stay on top of, let alone if you're trying to run an effective risk adjustment program.
So, good morning. This is Tom. I'm going to talk about building consensus. So, we've just discussed, getting to know each other and what that looks like, and what's important and why we want to do that. So, now we're going to take it one step further. We're going to be looking at the challenges of building that consensus. So, here we're depicting a multitude of issues that we all face in the industry today. So there's any one of these we've all had issues with, from collecting data, insufficient staff, bad coding, all of these issues, any one or more of these do have a negative impact on your risk adjustment scores as well as your HEDIS and P4P. So as you begin to work together with your providers, these are things that it's important to sort of like lay everything on the table and be transparent and talk about this. And I'm going to share an example with you right now about what happened to us not long ago in working with a health plan. So we have a health plan client who chose to parse out a piece of this information and deliver it to one of their provider groups. So we met with the provider group and we did some training, and we had live data with the physicians in the room, and the physicians actually called out members that they knew, in which we said that there was a gap in chronic conditions, and the physician said, wait a minute, I know that member, and I know I assessed whatever the condition was, and it was a couple months ago. Why isn't it there? And we said, I don't know. We had a meeting with the plan the next day, talk about the experience of the training, and we would share this question with them. Well, literally in 15 minutes of meeting with the plan, the IT person left the room and discovered there is a break in the data that was being extracted from their claim system to go to CMS. The plan had the data, but the plan didn't know that that data wasn't making it to CMS. So this small exercise, just a few hours, netted $7 million for this group. So the importance of transparency, this is just one example of why it is so important to want to work with your providers and the providers who want to work with the plans in order to uncover these. If nobody purposely sets out to do something wrong, but we all need to work together in this world for risk adjustment. Just as Rachel mentioned earlier about the rowing, we need to row together, and this is one step in that direction. So as we look at the building the consensus and developing these collaborative relationships, there are two strategies that all the organizations take on every year in this regard. So the first one is retrospective. This is where you're doing your chart reviews and you're trying to find missing data that maybe didn't get pulled out of a chart that you have. And this is sort of a situation where you are limited to what was documented. You can't affect it. You can't say, oh, call the member back in because this is all retrospective activities. So while we know it will always be there, it will never go away, and there will always be a value to that. The biggest value is becoming prospective. And I know the industry is moving in this direction, and everybody's at a different point in their evolution in this regard. But my personal opinion is this is really where you need to invest the resources, because this is where you can move the needle. So, and following that same theme of transparency, if I'm able to show data that's missing today for next year's payment, that's where you can actually have the biggest impact, because now you get to control what data you have or don't have. Make sense? So now we've identified strategies, and what's important with every strategy that we take on is we need to set some goals. And we've all heard the acronym SMART, if you've ever had to write goals for yourself. So following that same theme, we've identified some examples of what the goals might be. And we're looking at this really from both beginner, intermediate, and advanced. And if you're new in risk adjustment, it's really important for you to not to set the bar too high for yourself, because you will feel defeated. This is the sort of you need to walk before you run situation. So in the beginner category, maybe you're just looking at reducing the number of members who don't go to the physician. Those are easily done with outreach to the members, outreach to the doctors. So that's an easy thing. And maybe you want to look at doing improve your recapture rate. So that might be something that you want to take on and look for small improvements. And this, we're citing a 5% improvement for a particular doctor. So we're making the goal relatively small but achievable. And then moving on to the advanced category. So now maybe you're looking at a larger scope in that you're looking for maybe particular HCCs within your population. And again, I'm not saying every HCC, so make it manageable. So we're calling out two, so CHF and COPD. So, that's the kind of thing that you should look for. And then, of course, there's always the advanced. So if you feel you've got the first two covered, maybe you're at a stage in your evolution where you want to look at the RAPS and EDPS disconnect to ensure that they're more aligned versus what Rachel showed you just a few minutes ago. And this would be a strategy that you would have to involve your IT department, where the other two you wouldn't. This would be more of a risk adjustment team strategy. Okay. So I really like this saying. So this following the theme from what we just talked about on the prior slide. So this is, again, walk before you run. And this is a quote we took from Arthur Ashe. Start where you are, use what you have, do what you can. You know, again, you cannot boil the ocean, especially if you're new at this, at the risk adjustment game. So now that we've talked about some strategies and goals, one of the things that we feel is very important is the fact that you have to have a champion. So any kind of important or significant work, you need to have a leader. You need to have someone who's in charge and who's carrying the flag forward for you. So in this situation, we've identified it as a physician champion, but it could be someone else in your organization. But we find that physician champions are really the most effective, especially medical directors, because of their current role oftentimes crosses both financial and clinical arenas. So having a person with that kind of background affords a conversation that could touch on, if I'm talking to doctors, I probably want to focus on a clinical message, and if I'm talking to executives, then my message is more focused on the financial component. But again, because he's a physician, he does carry a lot of credibility for him. And then as the last item on this slide I just wanted to sort of touch on is that it's important if you can develop a team that comes from a variety of networks within your organization. So if you are able to gather some of your larger physician groups to become part of a panel to develop a strategy that, or implement a strategy that you're setting out for yourself. So, and as we do that, you know, we don't want this to be a sort of a one-time meeting, because it's important for this work to continue throughout the year. You can't take on a project and get it done in 6 weeks. So it's important to look at this in terms of the cadence. So whether you're meeting monthly, quarterly, you're doing dinner meetings, you know, whatever works best for your organization is best for you. So it's important for you to look at your situation, look at your scenario, and say, what can we do? What is achievable? And really, the goal with keeping these physicians engaged is to create a situation or a scenario where they can share challenges and develop solutions, as well as share best practices. You know, this is all part of the theme of transparency. And then, of course, you know, you may have these monthly group meetings, but having individual meetings might be necessary as well. So maybe there's a particular topic that you want to cover or with a provider group, or maybe you're a group and you want to meet with somebody at the plan. I encourage that kind of dialogue. So as we do this, it's really important that you don't set yourself up for failure. And so we need to recognize that there are some key issues that need to be addressed as you go down this path. And we've called out 5 of them here. I'm sure that there's more, but these are 5 that we felt were most important. And the one that tops the list, of course, is the lack of a formal job title or description. So if you're asking someone to take on some responsibility and you don't have clearly defined expectations, then you're probably not going to get what you need. So it's really, really important. And the next on the list is making sure that they have support and mentorship. So as you've identified who your champion should be, you need to also be able to support them with industry knowledge and any kind of change in regulation that may be coming down the road. So it's important for that person to be supported. You know, this is not a one-man task. This is a team effort with a physician at the lead or some sort of champion. The next one on the list that we felt was important was understanding their clinical workload and their physician champion duties. So if you're looking at medical directors still oftentimes have some sort of clinical responsibility as a part of their role. So you need to understand how much of that time is needed for that particular task. You know, maybe your medical director isn't suited for this role because they spend a large amount of time focused on the clinical workload. So that's something to keep in mind as you go down this path. Next, we have they don't have a say in decision making. So as we identify these champions, I think it's important to identify the kinds of questions that they may get when they're having these discussions, and then identifying what kinds of authorities can they have. What kinds of things can they say on your behalf of your group or your team? So you know, it's one thing to have a physician go out there and talk to your providers, but if they come back and they get some questions and they can't answer them, but now they feel like they're being ineffective. And so we want to make sure that we arm them with all the tools and skills needed for them to succeed. And then the last one on the list is really pretty obvious: fully selected physician champion. You know, this could be somebody who's maybe new to the system, or maybe they're an older doc and maybe they're a little resistant to the change, but they're your medical director. So it's really important to identify the person who's actually can take this message forward. So and remember, as you do this, you get to control all of this. You're not at the mercy of the results that happen, but you control this. This is where what you're really doing is you're setting yourself up for success by identifying all the challenges that you're going to be faced with. And again, you have control over this.
Okay, so back to Rachel for Working Smarter. So in Working Smarter, we have what we call the 3 rights, which is engaging the right person with the right information at the right time. And what we're showing here are some of the challenges that come up, whether they are before, during, or after the visit, and some of the possible solutions you can employ. There's a variety of solutions you can implement to address these challenges. Some of them are going to involve process changes. Some are going to be about education. There's a transparency aided by technology component to this as well, which we can show you, but there's no one silver bullet that's going to solve each stage. It's going to be across a lot of different departments. So let's talk about what are the things that happen in 3 critical moments: before the visit, during the visit, and after the visit. What I want you to keep in mind is remember back to the iceberg slide. I think what you'll see is it kind of loosely aligns to before the visit and what are their member gaps, during the visit and opportunities to improve what the provider is doing, and then after the visit we're going to talk around how there's some global issues that pop up in this scenario. It's not a perfect one-to-one, but I want to have you keep that in mind as I go through this. So first up, before the visit. One of the challenges before the visit is the member not visiting the provider. And possible ways to solve this are having member suspect lists, so you know which members to reach out to, doing patient engagement, such as phone calls or mailing letters and postcards to the members to encourage them to come in. And then there's also doing actual in-home visits. You may have a portion of your population that isn't mobile, and the in-home visits can help them to receive care that they might only receive when the situation becomes extreme enough to require them to go to the hospital, thus cutting down on your costs in the end. Next up is the challenge that may happen during the visit. One of those challenges could be that the provider does not diagnose or document the member's conditions. This could happen because the provider is unaware of care and diagnosis gaps, or the provider is unaware of the documentation requirements, or maybe because the provider incentives are not aligned or tracked. The possible solutions for this would be to provide provider education sessions, incentivization, or providing visit support tools. Finally, after the visit. Challenges that can occur after the visit are coding and billing, process failures, and/or documentation not submitted to CMS. And some of the possible solutions are performing chart reviews and data flow analysis and quality initiatives. One of the things we like to do is understand how data flows through an organization. And many times we've found that the priorities of your claims area and your risk adjustment teams are not in alignment. For example, claims is measured on timeliness of payment and not necessarily accuracy in terms of diagnosis codes. Do they key all the codes? Did they need all the codes to pay a claim? Probably not. Is it a no pay claim? What's their priority? Their priority is paid claims. Risk adjustment people is everything. So you need to understand that. And so through this data flow analysis, you can make it whatever you want. But the ultimate goal is always to make sure that everybody is on the same page, and understanding the disconnects is important. Now I'd like to walk you through a couple of examples of what some of those solutions I just mentioned can look like at these 3 stages. So before the visit, this is an example of our new member report, which can help you when you are looking to get members into the office. One of the problems we see on the health plan side when you have a new member is that is part of your plan coming in, you don't really know that much about them, what their chronic conditions are, because they're new to the system. So one of the things we find valuable in those situations is this new member report. It shows you a listing of your new members and the HCCs that they are coming to you with, so you know what they have been seen for in the past and will need to be seen for again, giving you something to reach out to them for. Okay, now for during the visit, now the member is in front of the physician. What we want to be able to do is arm the physician with all the information that we know about the member, so that the physician says, you know, oh, I need to assess you for CHF or for your bipolar disorder. So having that information in front of the doctor at the time of the visit, this is the prospective strategy that we talked about earlier. So the more information that we can hand to the doctor at that moment, the better job the doctor can do. And this is just an example of what we are looking at, historical diagnosis codes that were reported in the past. And yet, well, this example is 2016. We're looking for dates of service in 2016 in which those diagnosis codes have not been restated. So this is after the visit. So now the visit has happened and the members have gone in to see the doctors, yet we're still seeing gaps in care. So this is a snippet of a report that identifies specific members with HCCs that we don't see reported, and the point of service, the HCC, was first reported: inpatient stay, outpatient visit, or physician visit. And you can also see when it was last reported in the payment year. So if you're seeing a member here that you know was seen for a condition, this is telling you that the diagnosis code did not make it to CMS, and a chart review would be appropriate. While we are using this report retrospectively here, this report can be used retrospectively or prospectively depending on how you set your payment year. If you do a chart review and find codes that CMS does not have, you can do an encounter entry, export the file in the proper format, and get them submitted to CMS. Those are 3 examples. Another way to close your gaps is to make sure you're getting all of your inpatient data. One example I want to talk about is a case study, and it goes along with our theme of balancing retrospective and prospective. In the story, it starts out retrospectively, but as this plan went up the SMART goal ladder, they were able to put more resources into the prospective. The plan wanted to make sure they were receiving all possible risk-adjustable codes, and one of the ways they did this was pursuing inpatient data. They had many members that were not visiting their PCPs for preventative services, utilizing hospitals when acute conditions arose. So we developed a program where they engaged their in-network hospitals for 100% of their member inpatient stays. They did this for past dates of services, but also conducted concurrent pursuits to ensure timely reimbursement from CMS. They had amazing results with a 90% response rate and an annual value of $1.54 million from the additional risk-adjustable codes captured. This also allows for a more complete HCC data set to share with the providers, and then in future years use tools like the COC gap report to identify where they have some documentation gaps from these efforts, and going forward they make sure that they move the site of care from an acute care location into the physician offices, and they know what they need to document when they are doing that. Back to Tom.
So this is a sort of a depiction of what we feel are best practices to achieve the results that everybody's trying to work towards. So we'll start with the center. So we suggest that you have a single platform to manage all of your risk adjustment activities. So the screen shows various contracts, contract 1, 2, 3, but this doesn't necessarily mean you're a provider group with 3 Medicare contracts. You could be a health plan with 3 Medicare contracts, and oftentimes those various contracts run on different platforms and the platforms don't communicate to each other. But really, for success, we want to be able to put all that data into a single look and feel, so that as you're managing the population and identifying opportunities in strategies, that you don't have to replicate it 3 times. So this is the most ideal situation. And then as you look at your particular situation, we need to understand how flexible people are and where are they in terms of readiness. So in the lower portion here, we have providers who maybe are beginning, so we're suggesting risk adjustment 101 and some sort of in-service education, all the way out to I'm now at the far end of the spectrum. My goal is to become a 5-star plan. So it runs the gamut. And as we look at this, it's important for you to understand where you are and where do you want to go and where's your partner at. So you might be a provider group and your goal is you want to get the highest risk scores possible, but if the plan isn't necessarily at that same stage, you're probably not going to make it. So it's important as you work together that everybody understands where they are in the continuum. So here we have another case study. So again, these are real results that we're sharing with you. So we worked with a plan that had about 65,000 Medicare Advantage members. And their goal really was to identify members for closing gaps in care, looking at their providers, both at the group level and the physician level, to identify where they could help shore up those numbers by providing education or chart reviews. And then, of course, the information they wanted to share with the providers had to be timely. It's really important that as an industry, we recognize the role of the physician is crucial to succeed, and the information we give to that physician cannot be old. The last thing that anyone wants to do is hand data to a physician that is 6 months old, and the physician is going to say, wait a minute, I did this, this is old. Come back to me when you have newer stuff. So now you've lost them. And so we want to make sure that whatever we give them is timely and something that they can actually act on. So when we started this relationship, there were 3 solutions that we attacked. So the first one was identifying high volume providers who had a larger population, and they really were engaged. So they had full access to all the analytics, the same ones that the health plan had. We also looked at low volume providers where we were able to share health assessment tools and various reports to help them along. And of course, the outliers, these are the folks at the lower end of the spectrum. We can't omit them from the discussion. So we developed Risk Adjustment 101 education. And the results were truly amazing. So this strategy, they were able to close 38% of the gaps for members that had chronic conditions in the first year. And that change was $24 million. So very, very significant. And again, so these are 3 different strategies. Looking at the larger provider groups where you could, if small changes met big results in terms of revenue change, and looking at low volume providers to help bring them up, and those that needed education. So all of this is doable. None of this is unachievable. And the results, as you can see, are tremendous. So we've talked a lot about risk adjustment, and now I want to really focus more on quality. And what we've been able to do is combine quality with risk adjustment using the same prospective strategies. So as we have, we're providing physicians with historical diagnosis code information. We also want to be able to arm them with HEDIS measures, for example, or P4P measures or STARS measures that impact the reimbursement as well. So being able to do this at the same time is something where we minimize provider abrasion, and we ultimately result in improved quality care reporting and, of course, improved revenue. So again, everybody, we need to remember that each year the scores all start to 0, whether it's HEDIS or risk adjustment or P4P. Everything resets to 0. So now what we want to show you is something that you could consider doing, where you are combining both the historical diagnosis codes with the HEDIS measures. So you saw Rachel's example just a few minutes ago, where we said about arming the doctor with current information relative to what chronic conditions that the member needs to have assessed, documented and assessed. So by also folding in the HEDIS measures at the same moment really can help move the needle. So now you're asking the physician to do one thing at the visit, and that's to provide the documentation and the care for all these items, both risk and quality. So now you're creating some efficiencies here, and whether it's Mrs. Jones is due for breast cancer screening or Mr. Jones needed colorectal screening, at the moment that they're in front of the doctor is when you really can get the stuff done. So now we've given the doctors sort of their marching orders. So you're doing all these prospective strategies. But now we also know that as you're doing chart review and you're collecting all these diagnosis codes, the ability to also look in charts for HEDIS measures, in this case here we're showing a HEDIS measure, but this applies to pretty much anything that's quality related. We want to be able to arm people with the ability to also track information to affect this. So in this particular scenario, we're looking at a HEDIS measure for diabetes care, comprehensive diabetes care. And so we know what data is important for this measure to be flagged as positive for this member. So having the ability to arm your staff with tools such as this helps you move the needle again. So we're focusing on both on HCCs and quality. So they really do go hand in hand. And I understand that there's often different departments within a health plan, but those departments need to understand that their work does affect the others. So lastly, we want to talk about some continual fine-tuning. So we talked about getting to know each other, building consensus, and working smarter with some with some suggestions on how that might be. And then the last thing we want to do is now we want to talk about measuring progress. So we've got some examples here on this slide, and these are just our suggestions. And again, looking at the concept of SMART goals. So this is what we want to be able to do. And at the beginning, you want to maybe set some year-end and interim goals. And those interim goals could be things that you're setting every quarter. So while it's important to look at trends month after month, because sometimes you can identify seasonality to data, and there is some seasonality to this. But it's important to actually begin to measure how did you perform this quarter, and then the next quarter, and the following quarter, because those kinds of changes that you might need to make midstream are going to be easier changes rather than waiting till it's November and now you're at the end of the year. You have no time to really turn the ship if it needs to be turned. And then creating balanced scorecards. So whatever this is for your organization, it needs to be something that's easily understood where maybe you're just using red, light, green circles or whatever works, arrows. It's really up to you, but it's important for you to look at items over time so that you can report all that information throughout the organization. And again, measuring ROI. So everything that we do, your senior management is going to want to know, so how is it performing? Am I getting the results that I made? Is this achieving the goals? Did I set the bar too high? Did I set the bar too low? Is this the wrong tactic, period? We don't know that. And then as you do this work, it's important to make sure that the communication goes from top to bottom. So it's important that what you're doing is fed throughout the organization. So not only does the senior management know, but also you want to loop in maybe your claims department or your IT department, because they all have a role in this. And I think it's important for you to share what strategies you're doing and how their role impacted that. You know, everybody wants to feel included. So this is one way to do that. I can't stress that enough. And then celebrate successes. You know, all of us, we have, you know, 14 hours worth of work every day to do an 8. So sometimes it's hard to stop and celebrate, but it's really, really important to sometimes call somebody out for the work that they did or the change that they made. And lastly is the special recognition. So this could be something, this could be a provider group, it could be somebody within your organization again, and this recognition could be through newsletters, or maybe your company has some sort of intranet where you can post and celebrate these people, the impact that they've made to your numbers. So here's an example. We're calling this a Raft Leaderboard. It could be a scorecard, but what this is meant to do, really, the big picture is being able to look at your organization. In this case, we're looking at primary care physicians, and look to see how they're performing compared to their peers. You know, sometimes it is important to do that. You know, if you know what your average score is, it's important to know who is above and who's below. So in this particular example here, this report is actually two sorts. So we're looking at the groups with the highest membership and their scores. So I'm going to focus on the first 3 people on this list. So the first 3 doctors have relatively close populations that are assigned to them. Average ages are relatively close. But look at their HCC weight. So this is just the HCC portion. This is not the total score. But look at the difference in numbers. So physician number 1 on this list has a score of 1.057. I mean, that's awesome. I mean, we would love to have that. So the question is that real? And if it is, that could be your champion. The next doctor on the list, 0.487. So his membership, the demographics of the population is relatively the same. So what happened to physician number 2? So the next step on this would be contact the physician or the physician's office and ask questions such as, how does your data get to us? Are you using an EDI vendor? Are we getting your data? You know, there's some very, very basic questions that you need to find out. But when you look at data like this, now you know what is the tactic. You know, your overall strategy is to get your scores up, but how are you going to do that? And reports like this will help you do that. So as we look at all of this, it's important for us to look at feedback. And, you know, and so we talked about that in a couple slides ago about communication and all of that. But here's just some examples of where we think it's important for organizations to share what's happening and do provide some sort of feedback. And again, it's really up to your individual organization and your situation to say what would work and what doesn't work. You know, it could be none of these, but having standing meetings. So it's important for people to have regular check-ins. So I can say personally for myself, if I know that I have to report back on results of the meeting, you better know that I'm focused on getting those results because I have to report back. People are expecting me. Post debriefs. So you did a program. What was the result? So share some of that information. Webinars, provider forums. Just as we're doing today, you could schedule webinars where you're talking about a particular tactic or strategy. And then lastly, of course, newsletters. And it could be snail mail. It could be electronic newsletters. If you're a health plan, you probably already developed newsletters and sending that to your organizations. Maybe you want to add a section that talks about risk adjustment and what you're focusing on. So again, these are just some examples for you to take a look at.
So recapping, I hope in today's presentation you've seen the value of having transparency between the health plan and the provider, gained some strategies for building a consensus and developing joint goals, gained ideas and ways to work smarter, not harder, and seen ways to continually fine-tune your program to keep improving over time. I'm going to hand this back over to Sean now.
Great. Thank you, Rachel, and thank you, Tom, as well, for walking us through that presentation. Calling back to our opening slide, where we had people rowing in a circle, hopefully by implementing some of these lessons and best practices, we can actually look like this, be a well-aligned team where we're all rowing in the same direction, and though I don't see any other boats in this particular race, let's assume that they're crossing the finish line first and actually achieving what their goal is. So thank you again to you both. We do have a few moments here for question and answers. So I'm going to ask that any attendees, if you have questions, please use the portal on the right-hand side. We did receive a few during the presentation, and we actually asked ahead of the call as well. So I'll start with those, and then with time remaining, I'll go through the questions that we received in the presentation. So the first one up, and this was before the presentation, so hopefully maybe they don't still think this, but we'll see. And but I think it is worth asking because it kind of recaps the whole situation that we're in. And the question is this: with the payer challenging for control of the traditional physician-patient relationship, who will win this battle? I think it's interesting they use the term battle there. So I don't know, Tom, maybe want to give a few words.
Yeah, so that's an interesting question. I can tell that question came from someone on the provider side. But really, everything that we talked about today, the theme really was transparency. And transparency means that you share information with more than one entity. So in this case, we're talking about the providers and the plans. And so I don't see this as a battle. So in all my years of working in this arena and in healthcare, the plans do not really want to control the doctors. That's not their goal. Their goal is to make sure that the members get the care that they need, and that care is being provided by the doctors. And so the plans really do want to have a collaborative relationship, and so there's not really a battle and nobody's trying to control. If it's maybe perceived that way, it's probably from the fact that we know that the members, the diagnosis code information may not be reported to the plan, and so that's really where the plan's coming from.
I have another question here around chart review. And the question is about capturing diagnosis through chart review. One of our slides showed a claim editing screenshot. And are plans allowed to make adjustments to claims if the diagnosis is supported by the chart? Is this method documented anywhere on the CMS website? I guess first let's talk around, are they allowed to make adjustments?
They absolutely are. So one thing that's important, and I've shared this with all the people that we work with today, and that CMS does not care what your claim system says. So CMS has never said, show me your claim. CMS says, show me your medical record that supports that documentation. So in my years of working on the health plan side, once a claim is processed or adjudicated, it is locked down. You cannot change that. You can void and replace or make an adjustment to it, but you cannot alter that. So if you're finding something that is incorrect or missing from the original claim that's in your system, I would suggest that you go ahead and make that change through a chart review or whatever methodology that your organization is doing, because at the end of the day, CMS only wants to know, is that supported by the chart?
So on the second part of that question, where is there a certain way to handle adjustments through CMS? Is there any particular steps that you have to take to do that in the proper way, or is it considered the same a resubmission like your normal process?
Well, so there's two adjustments that you're going to make. One is adding a diagnosis code, and one is deleting a diagnosis code. So if you're the provider and you're finding data that's missing, ask your provider, how do you want me to send this to you? So you know, in our application, we've got, I think, 4 different formats of exporting data to a provider, from basic sort of like Excel type files all the way to something like a minimum data set that's 837. So that's how we get data to the plans for new data. If you're looking at deleting diagnosis codes, those situations do vary by health plan. This whole process, while it's been around for several years, there isn't any real standardized method as to how each plan does this. So if you're working with more than one Medicare contract, they may have different guidance and instructions. I advise you to reach out to them and let them know that I have some codes that I think I need to delete because the documentation does not support them, and then have them guide you on what their strategy is. We do have there's a functionality in the application that has that, but again, it varies by payer.
We have a question here on striking the right balance between prospective and retrospective activities. I know you had a slide on that, and I'll just go a step further from what this person's asking. Could you put a percentage to kind of ballpark? I understand it's going to kind of vary, but from where you're at. So, you know, if you're earlier on, you're probably going to be more retrospective, I'd imagine. Well, what would be like the ideal goal state?
So, you know, for me, I would probably use the 80-20 rule. If you can commit 80% of your efforts towards prospective activities, that's where you're really going to get the biggest result. And of course, you know, the chart review piece, the retrospective work never goes away. There's always some opportunity, but hopefully over time that retrospective work begins to diminish because you are now employing prospective strategies. But the 80-20 rules is what I would say there.
We have a question that's kind of around more of a current event. So we know from the call letter that the rollback of EDPF, that percentage to 15% in the next payment year, does that change your thoughts at all around how much to focus on this issue? And if I can kind of read between the lines, it kind of, I guess, comes down to whether you think that this is a beginning of kind of a rollback and end to EDPF, or if it is a minor kind of temporary pause and still the plan is to go along to EDPF. But your thoughts on that?
So I think this is a minor pause. I know that AHIP and several trade organizations and larger payers have been pushing CMS to delay the phase-in as it was originally announced. So I think CMS is realizing that their goal really is always to pay for the care needed for these chronic conditions. So it's not like they're looking to pay less money. They just want to make sure that the industry gets paid appropriately. And I think that they recognize the challenges with Medicare Advantage plans on being able to collect complete claims data. So that's, you know, most Medicare Advantage plans were in the process of doing managed care and not paying claims. And so I think that CMS has smiled upon the industry, so to speak, and that they roll back the percentage. I mean, currently this year is 25, but next year is going to go to 15. And who knows what will happen in 2019. But I see this as an opportunity for the industry to sort of get their house in order and get their processes corrected.
Wonderful. Well, thank you. We do have a couple other questions that had come in. We'll respond to those individually after the fact, because I do see that we are at our time. So I want to thank everyone, the audience, for joining us today. I want to especially thank Rachel and Tom for joining us to going through this presentation. If you'd like someone from CO to contact you, about what you've seen today, please visit our contact page on our website. And today's session was, again, recorded, and we'll be sending out a link to that recording in an email to you in the coming days. And with that, ladies and gentlemen, this concludes our webinar for today. Thank you again for your participation. I hope you all have a wonderful day.